Do you want me to comment on the, أول شيء thank you Doctor, يعني an excellent talk. Just two comments on the case that you presented. One of them is you said using ACE or ARBs. I mean, let me go take it further. There's, if you look at the micro-hope study, when they did a meta-analysis, actually they recommended starting ACE inhibitors, even the patient have a normal blood pressure. I'm going to even take it further. There's enough studies to suggest that a patient who are at high risk of diabetes, they didn't develop diabetes, you can go ahead and start them on ACE inhibitors, low dose or ARBs, that they can delay the appearance of diabetes. That's the first question. The second question is, you want me to comment on the blood pressure. In general, I agree with the recommendation because there are different societies with different recommendations. I think the Eckert study have changed our thoughts. But we still believe that lowering the blood pressure, targeting 120, 130 to 120 is the target. Because you rarely see a patient with diabetes without vascular disease. But if you see a patient with proteinuria, talking about 1 gram proteinuria, then you have to lower the blood pressure targeting 120. So I don't know if that's...
Well, I mean, in this case, probably I will refer to you and you do that. But for me, I will stick with less than 130 to 120.
Let's refer the patient to us.
Right.
Can I comment? Can I ask a question? So just to follow up on that.
Sure.
So the question is more about normotensives with microalbuminuria or moderately. What's the evidence to support using ACE? I think it's helpful in the first year, but at 5 years, I don't think it makes a difference. If Dr. Hassoun or our expert chair could talk about. And then my second question is regarding, do you consider using SGLT2 inhibitors in patients? Because it's not in the guidelines, but they do have a bit of a blood pressure lowering effect. So someone with a moderately elevated blood pressure, you start them on ACE inhibitor, and then they're still high. Do you consider these patients for SGLT2 inhibitors?
I'll take the second part. And again, SGLT2 is added benefit. We can use it. But if I have somebody for diabetes, I will use it for diabetes purposes. But taking in consideration, as you mentioned, it will help me with blood pressure. So if the blood pressure will control to the target I wanted to reach, I will stick with that. I will not add any other medication. Now, the first question, if I may, and maybe he can join us, our chairman here, I personally don't see so much evidence to support that. I don't treat somebody that having normal hypertension with some early, microalbuminuria. He might differs with us. But you know what I usually do? Look into the level that it is 130 and below. So if they are in the 130, above 130, I might consider them, putting them in that category, but not completely normal person.
I'm not going to disagree with you, but I'm just telling you the fact that there were enough data. I'm going to go back even in the early 80s, Dr. Ravid, even Dr. Ramuzzi from Italy, who has proven that if you start patient with ACE inhibitors early on, that was at that time captopril or lisinopril, and you start them early on, you can delay the progression of kidney disease if somebody has diabetes, so they would decrease by 30%. The effect is prolonged. But even in micro-hope studies and other studies that have shown that if you start patients who have a high risk of developing diabetes, you can actually delay the appearance of diabetes. So it's, there is no clear fact in that, but it's up to you, Doctor. You can refer them to us.
Exactly.
I totally agree with you.
When I have doubt, I will send to you. If I am ready to do it myself, I'll do it.
Doctor, I'm staying here for another 2 weeks, so you can send patients.
Yes. Any question?
Thank you very much. I think both of you, excellent speaker, and I'm grateful to you. I just want to mention 2 questions, but the answer is you, because I have to be really brief in my questions. I think now the endocrine people are really split between the use of statin and the danger of statin in patient health. And I think you mentioned, you supported the notion of using statin, but I think many people are split on this, and as a matter of fact, using statin can promote Alzheimer's disease and certainly dementia. And there is a paper which I probably won't refer to it, but we could discuss it later, that they gave a statin and the patient went to dementia, and then after that they stopped it and reversed the patient and so forth, and there is many other, and even the more you take carbohydrate, the more triglyceride you will find, the more LDL, and certainly most of the MI, it happened in patients with normal LDL, so if you go to any hospital and you could see it. I mean, the argument is really overwhelming, and we could discuss it forever, no doubt. Treat insulin resistant, and you will have low triglyceride, and certainly even low hypertension, no doubt about it. I don't know what's your view. Maybe the other could participate in this.
Thank you, Doctor. But just to mention regarding statin and Alzheimer, already it has been ruled out, like the cause of Alzheimer was not the statin itself, but the patients were already on statin and continued to take statin when LDL was very low, and it affected their nerves. It's not because of a statin itself. Triglyceride, yes, I do agree, insulin will reduce your triglyceride, but it depends on triglyceride level. That's why we said whether it's more than 10 or less than 10. Because if you are on diabetic treatment, and I have mentioned the effect of diabetic treatment on all the lipid parameters, and still your triglyceride high, then you should consider starting treatment.
Well, the argument could continue forever, there's no doubt, but certainly the LDL particle is more important than possibly the total LDL. And certainly the carbohydrate will lower the size of the LDL, and that's possibly atherogenic, and then, but now I think the view is that atherogenicity is related to inflammation more than related to LDL. But certainly the more carbohydrate, the lower the LDL particle. And that's possibly affect the atherosclerosis test and possibly will lead to MI, But
yes.
Certainly it's an argument.
Definitely, Doctor, the diet is very important, and that's why it was at the top of the list. Before even you start statin, you should advise the patient for lifestyle modification. As you know that our diet in the Gulf countries, it's very carbohydrate-rich diet, which can increase the LDL and triglyceride, as you mentioned. So diet is very important, and it is number one. Lifestyle modification, and then you should start statin according to the guidelines.
Dr. Ahmed, your view.
About which one? There's so many questions you asked. Give me one.
Well, the thing about the hypertension and the metabolic syndrome. I mean, why you don't go to treat the metabolic syndrome and forget about the drug if you have the time?
Yeah, who said we're not addressing? We're addressing metabolic syndrome, but if you address it and you did not reach to a target, still you have to think about the treatment of hypertension. I agree.
Thank you both. Outstanding talks and discussion. Ahmed, when you start for stage 2 hypertension, what is the preferred one for diabetics, the combination? A lot of colleagues, they use diuretics with the ACE and herbs. Would you do that? The beta blocker has been used a lot by our cardiologists, which is something I totally disagree. As a first line in our population with diabetes, we know the risk of beta blocker uses. So what's your take, and what is the combination you start from day one?
For combination, I agree with you. I mean, it's different. Now, we're talking about individual things. So if you don't have other issues, it's just hypertension to the level of, high level, I would go with 2 medication. I could use either. And usually, I prefer to use a combination. And this is, we did not have time to talk about. Single pill combination is always better for adherence of the patient, and studies have shown that. So anything that is available to me in a combination, I will do that. For example, amylo calcium blocker or even diuretic with an ACE or an ARB. I will use both. And there is no recommendation specifically, but generally speaking, ARB and ACE would be one of them, most of the cases here. Although it does not have to be, because of what you can see. It's only if you have albuminuria and coronary cardiovascular disease, it is recommended. But personally, I go with one of the choices available, which is ARB or ACE. And again, probably I would say, like my chairman said, I prefer the ACE inhibitor, tell you frankly, to start with if I can. And I always explain to my patient that you might expect to have cough, but I use a number, I say, from the companies they told us about, maybe it's correct or not, about 7 of 100, and I hope you are not one of the 7, and you are one of the 93 people who will not have the cough, to convince them of the benefit that I know about using it. So that's how I do it.
Thank you very much. Also, in addition to your question, Dr. Ruiam, I totally agree a combination of AC inhibitor and calcium channel blocker because proved superior when you look into ASCOT studies, a landmark studies in 2006, when they compare AC inhibitor plus calcium channel blocker in diabetic patient was superior than the standard medication of beta blockers and thiazide diuretics.
Yeah, I agree also with that. I personally favor to add a calcium blocker to the ACE and ARB, especially that we have it, together. I don't know, same thing probably in Bahrain, we have it together. Not with? Oh no, this is sorry, a good point you mentioned, and I find it myself also in our hospital. They right away have this bisoprolol. Everybody coming with hypertension having bisoprolol, and they are not getting the advantage of like the ACE and ARB, which is important, and they forget about it. They give this one, pressure is okay, happy with it. They don't add this. So I try to find a way to minimize the beta blocker because I don't want to stop it, especially they have maybe coronary artery disease, and to add some. And there is some combination now with bisoprolol and let's say perindopril. You can use them together.
Now we conclude our session with many thanks to Dr. Ahmed and Dr. Thank you. And Dr. Jihan.